This is one webinar in a series of webinars related to the global year. Before I introduce our first speaker, I would like to direct your attention to some information we have on the screen. For the Q&A, after the talks, we'll have a Q&A session, and you can type your questions into the Q&A area of your Zoom meeting control panel window. You can submit the questions at any time that you would like. We are also recording this webinar, and it will be available on the IASP website. You can also tweet using hashtag Global Year 2020 and follow IASP Pain on Twitter. Now I have the pleasure of introducing our first speaker, Dr. Lisa Holste. Dr. Holste is an associate professor in occupational science and occupational therapy at UBC and a scientist at BC Children's Hospital Research Institute. She holds a Canada Research Chair, and her program of research focuses on developing ways to reduce stress and pain to support optimal development in infants and children. I'll turn it over to Dr. Holste for her presentation.
Great, thank you very much. Okay, here we go. Oops. All right, thank you so much. I'm honored to be here today, and I'm going to talk about Calmer, which is a patented medical device for managing pain in infants in the neonatal intensive care unit. And what I'll review in the next 15 minutes or so is just provide you with a background related to the development of this device called Calmer, and describe the results of a randomized control feasibility study and end user evaluation of the Calmer that we have done. First, before starting, I need to do a conflict of interest declaration. So I am the lead inventor of this medical device for preterm infants, and in partnership with the Provincial Health Services Association, I could, in the future, receive royalties as a result of licensing agreements made with private industry for commercialization of the device. And related to what I'm going to be talking today, I was the principal investigator for the trial and the end user evaluation. I did not participate in the data collection. I had no access to the data being collected, to where it was stored, or to it before it was transferred for data analysis. And independent statisticians and researchers analyzed all the outcome data that I will talk about today. I'd also like to acknowledge that I'm presenting from the traditional, ancestral, and unceded territory of the Musqueam people, and acknowledge my sources of funding. So many of you on today's webinar probably know this background information, so I'll go over it very briefly. We have a clinical problem where preterm infants experience pain related to necessary medical procedures, and on average they may experience 10 to 12 painful procedures per day, and this may go on for weeks and in some cases for months. We know that this early exposure to pain can cause adverse changes in the brain. And currently, non-pharmacological treatments are recommended for procedural pain that is considered mild to moderate. And one of those treatments is skin-to-skin holding. Skin-to-skin holding is an effective human touch-based strategy, and it's used for promoting optimal development, sleep, growth, and for minimizing pain. And it's also been shown to reduce infection rates. There are some times, however, when it is not feasible to do skin-to-skin holding for all procedures all the time. And so one of the questions I had was, could we provide a non-human adjunct to care? This project started from an experience I had visiting a lab of a haptics researcher, and haptics is the study of human-computer interaction, particularly related to touch. And I visited the lab of Dr. Karen McLean, who was building robotic devices such as the one here on the screen that had attributes that could be considered human-like. This particular one, called Tamer, was a sort of a replica of a cat. So it purred, it had a breathing motion, obviously soft skin that could be touched. And in adults, the breathing motion was shown to reduce stress in particular. And when I visited the lab, I thought, I wonder if there's some way that we could adapt this therapeutic approach for babies in the NICU. But we had some key design challenges. We had to turn what's considered a visible robot, like the one in the previous slide, into an invisible robot. We did not want to have any humanoid appearance because we are not trying to replace mothers. We had to think about usability in a safety critical environment, issues around infection, noise levels, and emergency situations. It had to fit easily into existing infant incubators. It had to be portable. We wanted it to be individualized, and we hoped that users would find it acceptable. So the photos on this slide are of the latest prototype. This is the third version that we've just finished building. And what you can see here is a picture of Calmer. And I consider it an adjunct to care. It is not replacing parents. And I'm going to keep stressing that because that is not my goal. And what you can see here is a white platform that's sitting inside the incubator, and it fits the GE giraffe incubator. That's what it was designed for because that's the version that we have in our nursery. And as I said, my goal is not to replace parents. Parents are the most powerful implementers of skin-to-skin holding, and they should be of primary importance. So Calmer is meant to be used when parents and other family members are not available. So Calmer has three key pain mitigating components. It has a heartbeat sound that is volume controlled. It has a vertical 1 centimeter breathing motion trajectory and an artificial skin surface. And we can individualize the rates of the heart rate, of the heartbeat and the breathing motion for each baby based on a parent reading. So this photograph just shows a baby who's unwrapped for the purposes of the picture, just lying on the Calmer in an incubator. So we have done two trials. One first pilot trial that we did with our first prototype that just had 9 babies, and then a larger feasibility trial with 49 babies. And in both of those studies, we compared the Calmer treatment to our standard of care in our nursery, which is facilitated tucking, which is a human touch-based treatment. And we observed babies during a single blood test needed for medical care. There were 3 baby outcomes. I'm going to talk about the first 2 today: the standardized pain assessment using the behavioral indicators of infant pain and changes in heart rate variability. We also conducted an initial user acceptance study, which was qualitative, and we interviewed 10 mothers and 10 ICU staff members. So for the purposes of today, you don't need to look at all the details here, but the group characteristics between the treatment and the control group were equal, and the babies were about 1,300 grams at birth and about 29 weeks gestational age, and they were studied just within the first month of their time in the NICU on average. So with respect to our first outcome measure, this is showing 4 phases of the blood collection procedure. The baseline when babies were not on the Calmer, the treatment babies were not on the Calmer, then the baseline to where they are on the Calmer and it's running, then the poke phase during the Lance, and the squeeze phase, and the end of recovery is the 4th phase. And the babies in red are the Calmer babies, and the control babies who had facilitated tucking are in green. And what you will observe here is that there is no statistical difference between applying a human touch-based treatment with the Calmer robot. So remember, the control is facilitated tucking. And we had the same results, so the same graph here, the same phases of the procedure and the same group labels here. We also found there was no difference between a human touch-based treatment, facilitated tucking, and the Calmer across the phases of blood collection on the mean heart rate. I wanted to know whether or not the Calmer provided any benefit over babies who had not received treatment. And of course, that isn't ethical to do anymore, but I had access to old data from our nursery that had equivalent babies in it in terms of the gestational age and the age at testing and that sort of thing. And so I compared their pain scores during the poke phase with the Calmer babies and a no treatment control group. And we had about a 50% effect size for the babies on Calmer. So a reduction in pain scores. With respect to the qualitative interviews, the 10 mothers, we had 10 mothers whose infants had been randomized to the Calmer and 10 NICU staff. We conducted semi-structured interviews that were done by an investigator who was arm's length from the trial and from Calmer Development. She was a colleague of mine in the occupational therapy department. Data were analyzed inductively as per Braun and Clark's guidelines for thematic analysis, and the computer-assisted data analysis software InVivo10 supported this process. We developed 3 cross-cutting themes between the staff and the parents or the mothers. And theme 1 was that Calmer was considered a backup of me. And these 2 quotes reflect that theme. The first mother said, "I like the idea that it's impersonating me. I guess when I'm not there. I like the idea that my heart rate and pulse were taken into consideration. It wasn't just the average human." And a second participant said, "For me personally, if Calmer had been in my baby's incubator from day 1, I think it would have lowered my anxiety knowing my baby was being taken care of on that level." Theme number 2 was strengthening the mother-baby connection. And we have a quote from a mother who said, "To feel something that's close to me or something that's like me or whatever would be important because he's supposed to be inside me." And a staff member said, "I think that they would enjoy it because it's bringing that closeness, like the relationship between the mother, even though it's not the true mother." And then the third theme spoke to our question about how mothers would feel about Calmer in relation to other technology in the nursery. So was it scary or off-putting in any way? And so the theme was understanding Calmer as just a bed. And one of the mothers said, "I mean, you're full of machines and everything in the NICU anyway. So it, Calmer, is just another machine at the end of the curve. It wasn't scary. It wasn't, any impact on us negatively. I'm happy that she's on it." So that summarizes, I'll just go back a slide, that summarizes fairly briefly the findings from an initial feasibility trial and a very preliminary end user evaluation. And I do want to stress this is preliminary information because implementing technology in the NICU is a long road and we have much more work to do. But we were encouraged by these initial results. And I'll just move on and describe briefly what future plans are. So we do have other data related to this initial study. We have data related to the brain, and we also have longer-term heart rate variability data because we actually left the Calmer babies on Calmer for 6 hours after the blood collection finished. And we are in the middle of actually creating a new way of analyzing continuous heart rate variability based on the data from this study. We are moving forward on commercialization with Calmer, and we are in active talks with a major industry partner. And our goal is to have Calmer components built directly into incubators and to also have freestanding units available. And in fact, the industry partner mentioned that particularly during this time of COVID, that having Calmer available would have been ideal for many families in their country. But we're working as fast as we can and hope to be able to continue the commercialization at a fairly brisk pace. We do have now, as I've shown in the slides, a third prototype, and what we want to do is test this in a larger randomized trial and have babies on it for a much longer implementation time. And then the final thing that we're doing is I'm currently working with an undergraduate engineering team at Cornell University, And we're looking to redesign COMR for use in low and middle income countries where power sources and NICU beds and community units have much different requirements than do modern Western units. So although I'm presenting today, none of this work would have been possible without collaboration from a number of people to whom I am extremely grateful. This project has been 10 years in the making, and I've had fantastic help from everybody I've asked, and I'm very grateful for that. And I'll just end with a slide of our relatively new acute care center, and would like to now turn it over to Amy, who is going to move us up on the age range spectrum and carry on with the session. And
Thank you so much. So our next speaker is Dr. Amy Holly. Dr. Holly is an associate professor in the Department of Pediatrics at Ohio State University. No, sorry, at Oregon Health Sciences University, and the associate director of pediatric pain psychology in OHSU's Pediatric Pain Management Center. In addition to her clinical work, Dr. Holly studies functional outcomes in children and adolescents with pain with a focus on identification of risk factors that predict poor outcomes over time. Dr. Holly is the co-founder of the Advancing Research in Pediatric Pain Lab at OHSU and is a principal investigator and co-investigator on an NIH-funded research study studying pain in children and adolescents. Turn it over to you.
Great. Thank you, everyone, for joining this webinar. I'm honored to be speaking with you. Today, I'm going to be talking about my research program, which studies youth with acute musculoskeletal pain with the larger goal of identifying risk factors for the transition from acute to chronic pain, as well as to identify risk and resilience factors to target with future preventive interventions. I have nothing to disclose. I wanted to start this talk by sharing this picture. This image really illustrates why I became interested in acute pain as well as prevention research. So this picture was drawn for me a few years ago by a patient with chronic pain. And like the majority of patients I see in my clinical practice, and you may see in your own clinical practice if you see these patients with chronic pain, this patient had pain for several years by the time she presented for treatment. She had significant activity limitations, school disruption, elevated anxiety, as well as depressive symptoms. And thinking about this patient, as well as many of the others that I saw in my clinical practice, the researcher in me started thinking, is there some way that we can do better? So is there some way that we can identify a portion of kids who are at risk for developing chronic pain and start treatment earlier or start with some types of preventive interventions? So essentially, the goal of my research program went from moving treatment from here for at least a portion of these kids to here, to when kids have new onset injuries who are at elevated risk for poor outcomes that we could potentially target with some types of preventive interventions. So the first grant that I got studying kids with acute pain was a Career Development Award awarded by the NICHD. And as a part of this study, I recruited 88 kids with new onset musculoskeletal pain who were presenting to the emergency department or an outpatient orthopedics clinic. The study had 2 time points. So we recruited them post-injury and then a 4-month follow-up. And we collected self-report data, actigraphy, and we had these kids complete a QST protocol in our lab. It was a relatively small sample, being only 88 kids, but the study was novel and it asked an interesting question at that time. And on this slide, you can see some findings from that preliminary study. All of the data here listed on this slide are solely from that time 1 or post-injury data. But importantly, they really characterize the impact of pain on kids during the acute pain period. This is a little bit of a busy slide, I know, but essentially what our data showed is that, like in the context of chronic pain, we recognize that factors such as pain-related fear, sleep disturbances, parent factors like parent protective behaviors, as well as parents' own chronic pain status were associated with pain and pain-related disability in kids with these new acute injuries. The time 2 data from that study is listed here. And what we found is that approximately 30% of the sample continued to have pain at time 2. And we classified these kids as having persistent pain if they continued to have pain at that same location and had failed to achieve a 50% reduction in pain symptoms. We wanted to be extra conservative with that definition. We also found that psychophysical responses were important. So specifically, we found that less efficient pain modulation in that post-injury period predicted pain persistence at time 2. We also found that those who had less efficient pain modulation and higher depressed mood in that post-injury period had greater pain-related disability at 4-month follow-up. So fortunately, that data was interesting enough for us to get some additional funding. So I'm currently the PI of an R01 that's funded by NIAMS, but from the NIH, that's looking at doing a bigger study of kids with acute musculoskeletal pain. So what we're doing is we're bringing in 300 kids from 2 sites, OHSU and Seattle Children's, who are ages 11 to 17. And we're interested in really following them for 1 year to look at these pain outcomes and try to identify mechanisms of the transition from acute to chronic pain. Like the preliminary study, we're doing a variety of different study methodologies. We're having them complete health surveys, twice daily diaries. They're completing actigraphy, and we also have an expanded QST protocol. We're also interested in collecting just broader information on health history as related to, and also history of trauma, really to classify factors that are pre-injury risk factors that might impact if kids develop chronic pain or not, or continue to have persistent pain over 1 year. Unfortunately, because this trial is, or this study is currently underway, we don't have the longitudinal data yet at this time to present. But we have some interesting findings from our baseline data that are relevant to prevention and screening, which is the focus of this webinar today. So I thought I would just share a couple pieces of that early data. So first of all, one of the projects that we've been looking at is using the pediatric pain screening tool in rapidly assessing kids with acute pain for elevated risk. Many of you may know this measure. It was developed by Laura Simons and colleagues modifying Frank Keel's Start Back screening tool a couple years ago. And when they developed the PPST, it was specifically for a chronic pain sample. As you can see, the 9 items are listed here, and they're in a forced choice agree versus disagree format. And the scoring for the low, medium, and high risk groups is also listed here on this screen. And so a key question in our lab was, how would this measure work to screen kids who are treatment seeking with acute pain? And you can see the results here presented on this slide. So we found that about 1/3 were indicated to be high risk, 22% medium risk, and about 50% low risk. And the classifications did not differ by the demographic characteristics or factors related to the injury, such as the musculoskeletal pain location or whether the kid experienced a fracture or not. And what we did find, though, was that we saw some really key differences emerge between the low and high risk groups. So specifically, kids who were labeled as high risk had greater pain frequency and intensity, higher pain-related disability, higher pain-related fear, more pain catastrophizing, and more sleep disturbances than those who were labeled as low risk. While we don't yet know how this screener predicts study outcomes over time, because this is just that post-injury data. To me alone, this data in the acute pain period is important. We can just think about whether or not a screener like this can be used in the acute care setting, such as the primary care office, or when a kid is being seen in orthopedics, to identify kids who have additional symptomatology and may need closer follow-up. So also related to screening, we were interested in looking at parent risk. So Laura Simons, Anna Wilson, and I worked to develop the PRISM, which is a parent risk screening measure, a couple years ago. And this was for parents of kids with chronic pain. You can see the screener has 4 domains: parent distress, parent behavior, family impact, and parent health. And like the PPST, response options are an agree versus disagree format. And with the original measure, we published cutoffs to identify parents as moderate, high, or low risk. And what we found in our study with this acute pain sample was that 87% of these parents were listed as low risk, 8% moderate, and 5% being high risk. And risk groups did not differ by parent or youth demographic factors. We also found that the parents in the moderate to high risk group seemed to be very similar. So we conducted our analyses looking at moderate to high risk versus low risk groups. And what we found is that parents who were in those higher risk categories engaged in more protective behaviors of their kids when they were experiencing pain, endorsed having less distress tolerance, and also reported less ability to regulate their distress, and had higher catastrophizing about their kids' pain. This data was set to be presented by my current postdoc, Wendy Galtney, at the Canadian Pain Society in the spring. Unfortunately, due to COVID, that meeting was canceled. So we're hoping to work on a publication of this soon. But in terms of risk screening, like the PPST, I think it points to the importance of thinking about using this type of measure in the acute pain period. This may be a way to identify parents who need additional supports or psychoeducation about pain, perhaps even instruction in helpful versus unhelpful strategies for responding to their kids' acute pain. And then finally, the construct of perceived injustice, I know, is something that has gotten a lot of attention in the chronic pain literature in the past couple of years. And Dr. Megan Miller is one person who's really done a lot of great work recently examining perceived injustice in youth with chronic pain. So my graduate student, Eleanor Battison, and I were interested in looking to see how injustice appraisals in kids with acute pain were associated with pain and function. And she has a manuscript that's currently in prep for this, but agreed for me to be able to present it today. So what we found is that kids who had higher appraisals of injustice related to their acute injuries had poor quality of life, both physical and psychosocial, and also had higher pain-related disability. And we also found that discordance matters. So we were interested in looking at how child appraisals of injustice about their injury were or were not associated with the parent report of their injustice appraisals related to their children's injury. And we found that about 80% of these dyads were concordant, but 18% were discordant. And the discordance really appears to be important when the kid has high perceived injustice related to their acute pain, and the parent reports a low injustice appraisal related to that child's injury. And specifically, the group who really fell into this high child, low parent category had poor quality of life, higher pain-related disability, anxiety, depression, and pain catastrophizing in the kid. So with our longitudinal data, we plan to examine how PI changes over time and how discordance impacts these longitudinal outcomes. So the data I presented today has many follow-up questions, and there's a lot of next steps. Obviously, we need to look at that longitudinal data and continue to do prospective studies to identify the mechanisms of the transition for acute to chronic pain and better look at these risk and resilience factors over time. I know that in addition to my work, looking at doing these prospective studies, Jennifer Rabbits and Gabrielle Paget are doing some great work in surgical samples. And I know Emma Fisher is also doing some work looking at kids with acute injuries. I think we also need to really learn more about the timing of these preventive interventions, what's the best format, and who are we really going to target. And then I think this will inform over time really how much we really can prevent this transition from acute to chronic pain. Are there specific samples or specific populations that we are most effective with? I'd like to thank my lab here at OHSU and a special shout out to Anna Wilson, who is my partner in crime in running the lab. Also to our funders at the NIH, NIAMS, NIDA, and NICHD. And then, of course, my kids who have gotten to know a lot more about pain and pain research with all my working from home in times of COVID. So thank you.
Great, thank you so much. And now our last speaker is Dr. Katie Burney. She is a psychologist at Alberta Children's Hospital and an assistant professor in the Department of Anesthesiology, Perioperative, and Pain Medicine in the Cummings School of Medicine at the University of Calgary. She is also the assistant scientific director of Solutions for Kids in Pain, a national knowledge mobilization network working to improve evidence-based children's pain management through coordination and collaboration. Dr. Burney leads the Partnering for Pain Lab and conducts patient-oriented research focused on improving assessment and management of acute and chronic pain experienced by children, adolescents, and their families. She is a strong advocate for the partnership of patients and families in health research, healthcare delivery, and health systems design. And I'll hand it over to you.
Thank you so much for the kind introduction. And if you are a tweeter, please feel free to tweet at me and use the hashtag if you're interested. So I really want to go back to kind of the origins of our field when we talk about the role of patients and families in innovation in pediatric pain. And for those of you familiar with this bibliometric analysis led by Dr. Lena Case, it looks at all of the pediatric pain research, peer-reviewed publications, starting from the early days of our field in the mid-70s up until 2010. And you can only imagine that the field has continued to explode since that time. What I think is also really important, and this was taken from Dr. Pat McGraw's paper called The Modern History of Pediatric Pain that he published in Pain when receiving an award from the IASP Pain SIG. And what he wrote in it was that the modern field of pediatric pain was born out of a marriage of science and public concern. And without science, the public outcry would not have had a knowledge base. And without a public outcry, the knowledge would have languished for years before being adopted. And really with my work, I'm trying to take us back to kind of these origins, that these two things go hand in hand. We need the science. The science has to match and has to back up and identify and validate and challenge what's common sense or what's the experience of patients and families. But we can spend a lot of time creating science and creating new knowledge that doesn't actually go anywhere and doesn't actually make it into the hands of people who can use it every day. And some of you may be familiar with a paper that estimates it takes about 17 years to go through the research pipeline from early days, basic science, bench work, through to change in policy and practice. And when we talk about that in the context of pediatric care, that's an entire childhood. So we really need to be making sure that our science and public concern are really coming together in effective, impactful ways. And I really see, and I'm not unique in this, in seeing patient and family engagement as really the game changer. Involve is an organization in the United Kingdom that put out this definition of patient engagement, also called patient and public involvement, talking about research being carried out with or by members of the public rather than to, about, or for them. And this is really a shift from our traditional model of people with lived experience or patients as research participants exclusively, and really moving ahead to working to collaborate and partner with patients and families as members of our research team, similar to co-investigators or other collaborators. And in Canada, our primary research funder, called the Canadian Institutes of Health Research, has really been a strong proponent of patient engagement. And it's really shifted to be the new norm and the expectation that you have patients and families, in their words, knowledge users, as members of your research team. So what is the science behind this? What does it say about what the potential is for engaging with patients and families in this way? And I will say this is an emerging area of science, but what we do know so far, and this is from a number of reviews and looking across the field, is that engaging with patients and families as members of your research team can enhance the quality, appropriateness, and relevance throughout the research process, thinking from research ideation or idea all the way through to dissemination and impact. That this leads research to be more effective, more efficient, and more meaningful to patients and families. So we're asking the right questions at the right time and in the right way. And it increases the likelihood that research will be taken up into clinical care, which ultimately the hope is then that leads to better patient outcomes. The other hope behind this is that it avoids wasting research funds and efforts and in areas that are not important to patients. We can come up with a lot of great ideas ourselves as researchers, but we're missing a key expertise that lived experience can bring. So with that in mind, I started I'm now a faculty member, but started a postdoc with Dr. Jen Stinson at SickKids about 4 years ago. And early on in my days working with her, we developed this idea for a project that was really focused on bringing the patient and family voice into pediatric chronic pain research and care. So we received a grant from the Canadian Institutes of Health Research to really bring this original Partnering for Pain project to life. And our goal with a number of chronic pain clinics across Canada was to co-build a sustainable patient engagement strategy to guide pediatric chronic pain research and practice within Canada. So what we did is we tasked, one of our main aims for this grant was to undertake a research priority setting partnership. And there's a great organization in the United Kingdom called the James Lind Alliance that has set forth a really rigorous methodology for creating research priorities, identifying the top research priorities in an equitable, objective, inclusive way that really promotes the patient experience, the patient voice, that of family members, and also that of treating clinicians. So really 3 groups that are traditionally disempowered in how we prioritize and identify research priorities and what research should be done. So you can see our national group, this landed in a publication, and there are 5 people with lived experience who co-authored, who were equal members of our team across the country, including youth and parents, who worked as equal members of our research team and co-authored the publication that came from this. There are a number of research priority setting approaches. The James Lind Alliance is not the only, but it is identified in a review as being the most robust, strategic, objectively based, inclusive, and promoting equity. So that was part of our decision for choosing that methodology. So 4 steps guided our priority setting partnership, and at every stage, those 3 groups, so people who had lived experience with chronic pain during childhood, family members, and treating healthcare providers were included. And our first stage was a national survey, which really gathered priorities. And we simply asked, what priorities, concerns, or questions would you like answered by research with regards to chronic pain in children? We had several hundred Canadians across the country participate, and they shared more than 540 priorities. And this was a pretty diverse group. So in addition to siblings, parents, caregivers, we also had some significant others, boyfriends, those kinds of things, who participated. So the next stage was to take these 540 priorities, and with our research team of youth with chronic pain, parents, and other researchers and clinicians, we turned those 540 priorities into 112 testable research questions. So we combined duplicates, we combined things that looked at certain outcomes, and really looked across to end up with 112 different unique questions. We then took that back to a group of 57 Canadians, again representing patients, family members, and healthcare providers, who rated each of those research questions on a Likert scale of importance. And then we took the top 25, and those were discussed at an in-person priority setting consensus workshop together. And that group, again, was 20 people and comprised of equal members of youth and parents, family members, and multidisciplinary healthcare providers from across the country, working in different kinds of settings as well. So we're sure to ask our patient partners, what type of representation do you think is important at this final priority setting workshop? We were able to include an Indigenous family that lived rurally in Northern Canada on reserve, families that lived urban and had great access to care at chronic pain clinics, others who hadn't been seen at chronic pain clinics at all, psychologists in different settings, outpatient care, community care, different care providers like that, nurses, occupational therapists, physicians, and so on. So it was quite a diverse group. We also, as important to contribute to the science of patient engagement and the impact of that, we also evaluated our final priority setting workshop for quality patient and public engagement. And we used a tool called the PEAT, or the Patient and Public Engagement Evaluation Tool, that was designed by Julia Abelson at McMaster University in Canada. And it's a brief survey. I've just put up some of the questions here. Most of them are responded to on a Likert scale. With some open-ended questions as well. So I've pulled out some key items, higher mean up to 5, showing strongly agree. And just to show, this looks at process of patient and public engagement, that we did a good job, that patients and families who participated, as well as the other family members and healthcare providers, felt they were able to express their views freely, felt confident in the results that we arrived to through the process, felt that their voices actually made a difference to the project, and that the project itself would have an impact. I won't show this video because we're online, but I do encourage you to check out our project website and watch this brief video. It's about 5 minutes. You can see here one of the youth, Adam, who lived with sickle cell disease and chronic pain associated with that, who participated with his mom in the final priority setting workshop. It's a short video that really hears from the voices of the participants in the workshop themselves about the process, about the meaning of the process, and about the value of partnering as on a project team such as this. Here are the top 10 priorities that came from those initial more than 500 submissions. So the first one is, what treatments or strategies effectively prevent acute pain from becoming chronic? And you can already see through Dr. Amy Hawley's presentation before this that people are actively working in this area, but this is what we need more of. This is what patients and families and treating clinicians want to see. Number 2 was looking at the impact of chronic pain on academic performance and educational attainment, and what strategies best support vocational planning. And you'll actually see number 7 also ties into school. And for those of you familiar with pediatric pain literature, there is very little about school and vocational planning, academic supports, education for teachers, and so on. So this was a real priority from patients and families and clinicians that we need to do a better job addressing. Number 3 touched on physical and psychological treatments. Number 4 were strategies to improve access and delivery of evidence-based treatments and coordination of care, with a particular view to reduce disparities, and disparities being quite broad in conceptualization, not only families who live rurally and far away from chronic pain centers or tertiary care, but also those who may struggle to access pain care due to systemic racism and other challenges. The 5th was, what strategies effectively increase healthcare providers' knowledge and communication about chronic pain and its treatments. And I will tell you, the number 1 most common answer in our national survey was families recounting stigma, disregard, dismissing, feeling disbelieved from healthcare providers in their journey to access chronic pain care. So although we may think we're tackling this, we have a long way to go to figure out better ways to address this. They wanted us to look more at strategies that increase government and healthcare organizational financial support for evidence-based care. 7 was looking at educating school personnel, not just only talking about how to treat it and what supports are there, but even just the validity and the impact of what it's like for a teen or child to live with chronic pain. They wanted to know what interventions are effective for managing acute pain flares, what the interaction is between chronic pain and mental health, and when and how they can be most effectively diagnosed and treated together. I think this is also important because we know that a lot of studies don't address both together. We're really focused on chronic pain and maybe don't see the same benefit when kids also present with a primary co-occurring mental health condition. And number 10 was, when are treatments most effective? And this was a really interesting question because families and health clinicians really interpreted this in different ways. Families wanted to think about, well, presumably it makes sense to give us everything that is going to help right away. Whereas you heard a discussion from healthcare providers at the workshop about, well, what about readiness? And are we giving everything we know can help from a functional perspective at the get-go if the family's not ready to buy in? So I think we still have a lot of work to address around when and what type of treatment should be introduced at what time. I wanted to contrast this with some great work that Christina Leosi and others did in terms of research priority setting in pediatric pain and palliative care that was published a few years ago. And this was not specific to chronic pain, but I pulled out some of the priorities that were relevant to chronic pain, wanting to see more research on gabapentin, certain interventions in amitriptyline. And I really want to contrast for you the difference in how these priorities are focused when we've taken this patient-oriented approach. To my knowledge from reading this publication, there was some representation from within, of parents within this smaller group, but I think it's a shift of frame. It may be that gabapentin and amitriptyline or these psychoeducational psychological interventions will help address the patient-identified priorities, but it leaves us open and really focuses on what's the impact, what's the goal, what's the outcome, what will actually change in the patient's life, and finding the best treatment or intervention for that, rather than focusing on what one particular treatment is useful for or not for. So I think it may land at the same thing, but I think it's a frame of reference that I really think this rigorous patient-oriented approach brings. We also wanted to make sure that policymakers and health research funders would be able to act quickly on the priorities that we put forth. So I learned about this evidence and gap map methodology from a health economist in Canada. And I think this methodology is something I hadn't seen in the pain field before, and actually something I think we should consider using to highlight what evidence exists and where there are gaps. So it takes a little bit from systematic review methodology, but what we did is we reviewed all systematic reviews or clinical practice guidelines published in the past 20 years for any type of pediatric chronic pain intervention. We reviewed all those systematic reviews for quality using the AmStar2 rating tool, and we landed at 50 systematic reviews, including 2 clinical practice guidelines that were included. And this is what our evidence and gap map looked like. So I'll just orient you to it a little bit. The columns themselves are different outcomes. They're drawn from the existing pediatric impact guidance. And then you can see the groupings for each row of the different types of interventions: psychological, physical, pharmacological, and otherwise. And then the interdisciplinary interventions. Each bubble represents quality in different colors, the red pink color being critically low, up to the darker green being the highest quality. And they're mapped out into the number and quality of systematic reviews that addressed each of those interventions into each of those outcome buckets. And what you can really see is most address pain intensity, which is not a surprise, but there are lots of outcomes which have gaps, like sleep or economic factors, or even things as simple as treatment satisfaction. And you can also see a greater abundance of evidence for psychological strategies relative to others like physical intervention and pharmacological interventions. Now, this doesn't address how effective each of these are, but it maps out where we have gaps in our knowledge and where we have enough knowledge that policymakers and others can make decisions. And I think this speaks to not only the amount of evidence, but also some of the systemic things that arise. We all know that physical interventions are key to chronic pain management. And I think this reflects more that there's a lot of psychologists that get PhDs, whereas there are much fewer physical therapists or other rehabilitation therapists that do, lending to less research that's being done in those areas. We also mapped out the existing evidence relative to the top 10 priorities that were identified. And what you see is lots of gaps. A number of priorities where no systematic reviews addressed those, or some where there were only very few of reasonably poor quality. So it really speaks to areas where we can increase and match some of our research funds and our research activities to address patient-oriented outcomes. So much of my research program now is about taking action together to address some of these top 10 priorities. And I'm doing this and continuing to take this patient engagement approach with youth or parents involved as compensated equal members of our research team, from initial grant application and idea through to dissemination and impact. We have a grant right now looking at innovations in virtual care to address that priority around coordination of care, access to care to reduce disparities, and particularly relevant, obviously, right now in our new COVID reality. We also have a grant to co-design pediatric transitional pain services, so bringing together patients, families, health administrators, managers, researchers, and so on to co-design new services that help to prevent the development of chronic pain after surgery. Here's our virtual care solutions work that's underway now. Our first phase was to do a systematic review looking at existing best practices, editorials, opinions about virtual care for youth. So we have some of our work that we've shared. We found 16 relevant scientific articles published in the past 10 years, and this publication is currently underway. And then our second phase is to create an interactive evidence and gap map that will live on our website that maps out all different virtual care solutions across a stepped care continuum, so population-based up to tertiary care to support youth with chronic pain and their families. So we've conducted our scientific literature search, we've done our app and website search, and just completed, closed a call for innovations in partnership with SKIP and the Canadian Foundation for Healthcare Improvement. So this is all underway and will go live on our Partnering for Pain website later in November. I just want to, these are all photos of me with some of our youth and parent partners lobbying on Parliament Hill with SKIP for chronic pain care for kids, co-presenting at scientific sessions, or with national groups that are working to develop national strategies for chronic pain in Canada. And through one of our youth patient partners, Justina, she does work with National Canadian Pain Task Force through our Government of Canada. And these top 10 priorities in our project were integrated into the first report. So really, I've learned that this also helps bring your work to life. People are much more open to listening and hearing and seeing and bringing impact of your work when it also comes out of the mouths of people who have their own experience to tie directly to it. And just incredible acknowledgements and gratitude. That's a photo of our final priority setting workshop group, some of the co-investigators on some of those projects, and then a list of a number of the patient partners we've worked with. Thank you very much.
Okay, great. Thank you so much. We have a couple of minutes left for questions. So I have two questions right now. I think they're both to Amy. So the first one I have says, what types of QST are you including in your TEMPO trial, and do you have any preliminary findings or expectations as to what this data will show?
Great, thanks for the question. Yeah, so just briefly, the protocol that I'm using was developed by Jennifer Rabitz up in Seattle and I both, and she's using it currently in a trial in a study looking at kids who have just had a major surgery and looking at post-surgical pain. So we're using threshold, tolerance. We are looking at temporal summation as well, in addition to pain modulation using both a heat and cold. And in terms of what we're expecting to find, one of our hypotheses that I have for the study is kind of thinking about this pain modulation profile as one of the mechanisms of the transition from acute to chronic pain. And I think that's supported by some of our preliminary data. So I guess we'll just have to stay tuned to find out what the results are. But we bring kids into the lab, and it takes, I would say the whole protocol takes about 45 minutes or so.
Okay, wonderful. Then the other question that we have here for you, Amy, it says, with regards to perceived injustice, can you talk more about the questions you asked? Are the children and adolescents blaming others for their injury? And how do you think we can work to get parents and children on the same page in terms of injury or injustice around injury?
Great. So the questionnaire that we are using is called the Injustice Experiences Questionnaire, and there's a version that's validated. It was modified for children, and then there's a parent report version. And a couple of the items are specifically just related. I mean, there are a lot of different types of questions, but a few examples would be, are like, my life will never be the same. I just want my life back. There are things related to sort of, I'm suffering because of someone else's negligence, or I feel like this has affected me in a permanent way. And I think it's a great point in terms of thinking about what we do if parents and children are different in these injustice appraisals, because it does seem like with Megan Miller's work in the chronic pain sample and our preliminary data in acute pain sample, that this discordance does matter. And I think we have a lot to think about sort of what we do with that. But I think initially thinking about parents who may report less injustice or appraisals regarding their kid's injury than the kid is feeling may seem like they are dismissive of their kid's injury, or they're not validating where their kid is coming from. And so thinking about how we can sort of help that parent maybe listen more to that child's experience. I think, though, as we all know within pain, we also risk we want to make sure that parents aren't overly attentive to pain symptoms and overly protective of their kids when they're having pain. So I think it's definitely an interesting line and a fine balance that we'll have to take there. So happy to chat more with you about the questionnaire or kind of the work we're doing related to that.
Great. So another question that we had says that it was interesting to see that your information, Amy, showed sleep as having a strong modifying impact on pain, but that there was lacking research on sleep, which Katie identified. Do you know of any research, either of you, going on to address the gap?
I was going to leave that to Amy if she wanted to add. I mean, certainly there are studies that have looked at sleep. I know Tanya Palermo is on the line, I think, and so there are lots of people who are doing great work in that area, and certainly some interventions do address it. I think it also speaks to both kind of a need for further research in that area and inclusion in that as an outcome, particularly beyond psychological treatments. So including sleep as an outcome, for example, in trials that might look at medications. So I think that's one thing. I think it also speaks that in systematic reviews, people don't include sleep, when they're looking across trials too.
Yeah, and related, I agree. We've done a lot of work within chronic pain literatures looking at sleep pain associations, and I agree Tanya's group up in Seattle is doing some great work intervening on sleep and grants. I think that we can continue to focus on sleep in acute pain populations. I know Jennifer Rabitz's work in surgical samples has identified that sleep does impact outcomes following major surgery, and so I think the more we can continue to sort of take what we know from chronic pain and continue to ask those questions in the acute pain samples, to continue to think about how we can best assess for risk factors related to sleep at time of acute injury, and then also do some types of preventive interventions for kids who may be having some problems in that area.
Great. Well, it looks like we're at the end of the hour here, and I want to thank everyone for joining us today. A recording of this presentation will be made available on our website, and you can find out more information about any of our Global Year activities and future webinars on our website as well. I would like to invite you. The next webinar is next Thursday, October 15th, about addiction and chronic pain prevention. So might be a little bit different than this audience, but if you have any colleagues that are interested, please pass along that information as well. Thanks everyone for attending today, and I look forward to seeing you next time. Bye-bye.